we're talking about talking to people. You want to meet the patient where they're at, right? If you start going off on overly medical complex jargon and you have a patient that doesn't know what you're talking about, you're going to lose them right away.
All right, welcome to the show. We'll be talking with a board-certified oncology clinical specialist. He works at Stanford Healthcare. Bringing a unique blend of words that I think a couple years ago we didn't use very often. And I'm glad to see words like empathy being brought more into a conversation, right? In the world, would we be okay with less empathy? I don't know. I think we'd be worse off. So our guest is works and shares expertise to acute care PT, specializing in helping patients navigate the challenging journeys of oncology, bone marrow transplants, cellular therapy. Let's welcome to the show Adam Matichak. Adam, welcome to the show.
Thanks for having me, Jimmy. Let's start with Happy New Year.
Happy New Year. It is a Happy New Year. Do you do resolutions, intentions, or you just show up for work the next day?
I just show up.
I used to do that. I do like the idea of now people are like intentions, like January 1st is just a date, or January. I did like what I saw on social media, which isn't what you hear a lot of people say, like, oh, I did like people I saw a lot of this, and I don't know if it was the same type of group of people, but they were saying, listen, why wait till January to start whatever it is? What are you waiting for? So whatever that thing is, hey, start in December and you'll be 1/12 ahead of where you would have been. And I sort of like that idea, which is 1/1/2024 isn't a start date. It's just another date.
Well, and I feel like the other issue that people have when they're like setting that like January 1st, I'm going to start doing this, is that then if they don't start, it's like, all right, well, I'm going to like, do I start next week? Do I start next month? Do I start next year? Like,
right.
People put too much pressure on themselves to.
I always like to watch. I always like to watch what kids do, because I think kids are smart, because like they're not soiled with all this other stuff. But one bad thing kids do is they're always like, I want to restart. Oh, no, that's not that. That was a practice. Although it is a good way to look at stuff, which is like, all right, I screwed up. Okay, well, that wasn't the real one. Now I'm going to do it. Now I'm going to do it. And you never need to teach kids that. They just know it.
Yeah.
All right, so we get the hardest questions out of the way first. What are we drinking, Adam?
We are drinking coffee, actually.
Okay. But for the people not watching the YouTube video, you have a little bit of a collection behind you. And I would like you to help me understand. I see, is that Bullet? That's Bullet. I recognize that bottle.
Yeah, that's a pretty recognizable bottle. The red wax should be a recognizable bottle. Maker's Mark. But yeah, we got the... here, we'll take you on a tour of the
some of the ones I don't know? Yeah. Which ones do you like? What are like, I feel like we're on The Price is Right or something. We're doing a tour of but what's one thing on that bourbon shelf that maybe I wouldn't have heard of that you're like, you should try this?
Well, if you can find it, Stag or Stag Junior is excellent. It comes in at a great price point. Should be able to find it for $65-$70 a bottle. But they range in proof from like 125 to, I think my bottle up there is like 131 proof. It is
it's got
an excellent nightcap. But I'm more of a rye fan, especially during wintertime. I like the spiciness of it. So
yeah. Someone got me a bottle of rye. What's the difference?
Just what they're made out of. Yeah. So
to me, rye
is gonna.
Like, good enough. Great.
Yeah.
Well, I'm drinking a vintage. If you can get your hands on it, the price point's about $1 to $1.10 per bottle. It's a Miller Lite, because it's like 4 o'clock where I am, and I've had a long day. So cheers to your coffee, and I'll cheers to my Miller Lite.
Cheers.
All right. So Adam, you get to sort of like impart wisdom from the paths and the places that you've walked. So we're doing this different format for an episode where we call it a 6-pack, where we're sort of picking an idea, and yours is going to be like 6 things a board-certified oncology clinical specialist thinks every PT should know, right? And we've got 6. So I'll set you up, and then you knock it down. All right? So first up, your words matter. So what does that mean? How do you use language positively to positively influence patients, their experiences, their families? I call it the solar system, everybody around the patient during their rehab journey. Words matter.
Yeah. I think it's a great one to start with, right? Because we're talking about talking to people. And so your word choice, you know, you want to meet the patient where they're at, right? If you start going off on overly medical complex jargon, and you have a patient that doesn't know what you're talking about, you're going to lose them right away. And then also, we want to stay away from like over stigmatized language. Uh, there's been a lot of chat on social media about patients not adhering to things, not being non-compliant with their exercise program, things like that, and it just puts such a negative stigma on the patient that like you come to the clinic, or on the acute care side, I'm coming to see you however many times a week, and I'm putting in all of this work to try and help you get better, and you're not carrying your load on your side of things. When there is so much more that goes into patient compliance with an exercise program, or do they have time to do it? Even if it's as simple as like, hey, I want you to go for a 5 or 10 minute walk every day. Do they have a safe place to go for a walk? Do they have someone that can watch their kids while they're doing their exercises? Are they working multiple jobs to try and make things meet ends meet for their family? Like, we need to dig a little bit deeper and have a better understanding of the patient as a whole, and not just, this is what you have going on. These are the things that I'm prescribing to help you get better. You need to do them, or this isn't going to work.
Yeah. All right. So number one is your words matter. Number two, people don't typically do things or step out of their comfort zone unless it at least feels like what they're going to try is a little bit safe. So what strategies do you use to create? I mean, I think that the term is safe space has been sort of like bastardized, right? But like, how do you sort of at least, right? Like that, I like to picture that idea of the monkey bars, right? Is I'm going to have one, I got to have a grip on the one forward that I'm going to swing towards. That is the only time I'll let go of the one behind me, so I can actually move forward. So what strategies do you use to create a trusting environment, we'll call it, for your patients?
Yeah. So for me, working on the acute care side, right? I'm a big guy. I'm over 6 feet tall. I'm as wide as the doorway of their room. So, like, if I walk up to a patient's bed and I just start firing questions at them while I'm casting them in shadow, like they're not going to be very open with me. So, no, it's get down on the patient's level. Make sure that you have a comfortable amount of space. That if you're a loud person, a loud talker, try to bring the volume down a little bit. When you ask a patient a question and they're either having trouble coming up with an answer, or they're kind of rambling a little bit, give them that time to process what you're asking them, especially when you're working on the acute care side. They're in the hospital. They're not sleeping great. They're not around their family, their pets, things that make them feel comfortable. A lot of my patients, my bone marrow transplant patients, they're in the hospital about a month. That's a month that they're not at home in their regular routine. So I encourage, like little things that I can do. I encourage patients to have their families bring in, a blanket from home, put up pictures on the wall in their room, make that room, if you're going to be stuck there for a while, make that feel as homey and as comfortable as you possibly can.
Yeah. These are all small, not they're simple, but not easy, because you have to make them part of your routine. Everything you just mentioned was zero cost and required zero certifications or courses to do them. It really it required like thinking about what you do. And I'm guilty of those things because I can talk fast and I can talk loud and I do those things when I get excited. And that's something I've paid attention to, which is like, slow it down a little bit, because and I work with people like this too, like in public speaking. I'll say, you thinking you're slowing down by 50%, you've probably slowed down 5%. You can go a lot slower and still sound like you have momentum. And that goes whether you're giving a TED talk or whether you're having a one-on-one interaction with a patient, because both of those things, the goal is actually achieving understanding, not just
Yeah.
having got the words out.
Yeah. And so, right, when we talk about like asking a patient a question, and if their response is kind of trailing off in a direction that you don't want to go, but you're immediately cutting them off and not letting them finish their thought, and it's just like this rapid fire question. Now those answers to their questions are starting to get shorter and
Yeah.
shorter and shorter,
Yeah.
and now we're not getting those little nuggets of wisdom that we want to get, because we're not like, it takes what, an extra couple minutes to let them ramble a little bit and finish a thought. But there's so much pressure on, I have this like 15-minute block of time to get as much information out of you as I can. And I think that leads us into one of our other topics, right? Where this is not an interrogation. Like, we are
Right.
not sitting here with the FBI bright light shining on them, firing questions at them to get answers. We need to be able to pull out what we need from what they're telling us.
Yeah. Yeah. This was a cool moment for me, or at least made me feel like I had something to offer. Back when I was in PT school, we were learning the subjective exam, and we were supposed to study these like 10 or 12 questions in the order that we had to ask them. I remember I raised my hand. I was like, I've been interviewing people for years. How do you know what second question to ask where they haven't answered the first one yet? It's to choose your own adventure. It's like, I don't know
Yeah.
to go left or right at the next fork. I don't know what the next fork is because we haven't traversed the first fork yet.
Right. And then, you have a student that's on rotation with you. And right, we all get that same class where, these are the questions you need to ask, this is the order that you ask them in. And now you ask your first question, and they answer like the first two or three questions within their first one, but you don't know how to jump to that next question. Now you're just like,
Right.
oh, okay. Like, you just get stuck, and it's like,
Correct. And that's a nonverbal way of showing I'm not paying attention to what you're saying. Or this is I'm going off of a clip. I'm going off of a clipboard. I'm just repeating.
yeah,
Yeah.
yeah,
All right. So the third thing you think is silence. Silence is golden. And I think that people don't understand how powerful silence can be in again a TED talk or patient communication, and how
yeah.
effective can it be? Because the first thing you said was, I'm a big dude, I'm wide, I'm tall. If I'm standing above you, I'm towering. Silence is a great way to give space.
Exactly. No, and I think we already touched on it a little bit, right? If you're asking the patient questions that, we need information from them. We need to know, kind of what's bothering them, what past experiences have they had. And if those past experiences have not been positive ones, like, I feel like very few people are going to immediately like, this is what went wrong the last time I saw a PT, right? You'll get there eventually, but it's not, most people, it's usually not the first response that they're going to.
This is a cheat code, a completely legal cheat code that even the people you're asking are okay with it. And this is what I use in business communications evaluations. Walk me through what hasn't worked, and then guess what you're not going to suggest on your business pitch or your treatment plan. Like, that's a cheat code, man, and that's legal.
But when you're, like we said, when you're just kind of firing questions at them and you're not giving them that time to process what you're asking them and give them time to come up with a thoughtful response, that's where, being able to put the brakes on a little bit
Yeah.
and slow yourself down and think about the information that you're trying to get, not the answer to the question that you just asked them. Think about what
Yes.
you're trying to pull out of that question, right? If I have a patient that was diagnosed with cancer, right? They're going through all of these really tough treatments, and, I want to get them to be more active while they're stuck in the hospital with us. If I, ask them, hey, how do you feel about doing this today? And they're having a lousy day. If treatment's kicking their butt, if they got a lousy night of sleep, if they're, puking up everything that they eat and they just feel run down, you know, if I can give them some space to like, and I ask them, hey, what did you enjoy doing before you got sick? When you're at home with your family, what kind of stuff do you like to do? And how can we now, take the information that we're getting? Oh, like this is where I live. This is, beautiful places to go hiking. I love to go walk outdoors with my dogs, and now, great. They like to go for hikes. They like to be outdoors. Is there a space, in the hospital that I can take them where they have a nicer view than walking around the hallway staring at, the same set of doors and closets and, but if I just go, hey, do you want to, these are the exercises I thought would be good for you. Do you want to do those today? Like, no, I feel like crap. I don't want to do that today.
Correct. Sell the out, or bring the outcome, bring the happy thing into it. And then, because if I understand why I'm doing this, by doing this, you'll be able to get back to doing that sooner. Your next thing on the list, which is number 4, you sort of touched on it, which is ask without interrogating, right? Are there any like phrases or things that you use? I don't want to call them tricks, but like, I think they're tools more than they're tricks. I have a few. I'm interested in what yours are in terms of how to make a question feel not like an interrogation, because it shouldn't be.
Yeah. I think, going back to the last example, and it's not just like, what do you do for exercise? It's, what do you do to stay active? What do you enjoy doing? I feel like leaving things a little bit more vague, really open-ended, and not these really simple, I go to the gym.
Yeah.
Okay. What do you do when you go to the gym? There's lots of stuff to do when you go to the gym. What do you like to do? What keeps you engaged? What keeps you active? When you're at home, what is your family situation like? Not who lives with you, where do you live? Do you have stairs? All the, we need to get to those questions. We need that information, but I don't need to fire off questions like it's a bullet point list that I have to get through before the bell rings and it's on to the next patient.
Nobody wants that. Nobody wants to be a thing on a checklist to be, moved along the assembly line. I like one when you're receiving. Some people have pushed back on taking a patient history and said receiving a patient history. It seems a little, I don't know, whatever. That's fine. I like that. But one was where's this, instead of saying like, what brings you in today, which is a fine question. I like, where's the story start? Where's the story start? And sometimes people will think, I had an injury when I was 12 years old. I'm 39 years old. I'm like, if that's what you think, what am I going to do? Tell you you're wrong? That's a bad way to start. So where does the story start? And then let them go, right? The other is help me understand. And I got that from a former FBI hostage negotiator, Chris Voss. Everything's help me understand. It's like, help me understand means you're in charge. It says a lot in just a couple of words. Help me understand. Yeah. 3 words, really powerful. I like those tools.
Right. You talk about, getting a patient to trust you. Yeah. And it's not, I have this fancy degree and this alphabet soup after my last name. It's, tell me where you're at with things and I will let you know how I can help you with those things. But when you go into it with, this is your diagnosis, this is how we get you better. You're completely disregarding the patient's individual experience, what they've been through.
Correct. Yeah. I usually coach people up for, again, podcasts or talking to people, which is what a podcast really should be. I say you're allowed 1, maybe 2 follow-up questions with that. So I can say like, how's things going? Help me understand that a little bit better, which means you gave me a little, I want more, but I'm not going to go, what else you got there? Help me understand a little more about that. Or is that all? Is that all? Is there anything we didn't talk about, or I want to give you a chance to? So I usually say, like, if you want to go deep, 1 or 2 follow-ups, which again are just open-ended, Yeah. But those are great questions. And they aren't, it's hard to teach those in a orthopedics class in PT school because it's hard to give a test on that. But that's where the magic happens, is the stuff that's hard to actually put into a test, right? Yeah. So that ask without interrogating. Patient-centered goals. I feel like this one feels like we understand it, but how do you work with your patient to set and achieve goals? And you talked about this in terms of hiking or with their pets. How do you bring about the conversation? When do you bring about the conversation? Is it the beginning, middle, end of a conversation that are meaningful to them? Goals that matter to that person.
Yeah. So when I am receiving a patient history, I'm using that from now on. I try to kind of weave that goal setting in, while I'm talking to a patient.
Yeah.
I feel like we don't have to, do like a big dump at the end of our,
Right.
subjective where it's like, all right, like these are our
No
goals now.
goals.
Right? Because now we're just getting back to, bullet point checklists, like
Right.
these are what we're going to accomplish. I try to weave it in a little bit while I'm getting to know people. Um, and trying to make that connection, right? Like, okay, like you like to go hiking, you like to play golf, like, great, we're gonna, you're an avid golfer, but now you have, chemo-induced neuropathy in your feet, your balance is getting worse, right? Are you going to be able to stand over a 6 foot putt and feel comfortable on your feet, right? So we're going to work on your balance while you're here. When you go back home, take a handful of balls and go stand on the putting green and, shift your weight back and forth on, left foot, right foot. That's going to help you work on your balance, and you're going to do it in a way that is engaging for you. You're not going to,
Yeah.
I'm not going to have you stand at the kitchen counter and, set a timer for 30 seconds and stand on your left foot and then do the same thing on your right foot, because you're going to get bored with it and you're never going to do it again.
Yeah. Yeah. Make it meaningful to me. Clearly communicate the dots, right? There's a straight line between every 2 points, right? Help me understand why I'm doing this. Is it just to check off on your list that's not meaningful to me, or is it going to help me do that thing? That's all you needed to do to get my dad out of bed and shift weight was like, we're going to work on your putting. All right. And you want to sink the 6 foot putt. Last thing in your six pack is a phrase that I think I didn't hear about it until a little more than a year ago. And then I feel like it was everywhere on PT Twitter, and then it died out. And that was trauma informed care. So what's your explanation of the principles of trauma informed care, and how do you integrate those into practice?
Yeah. And so I feel like I had like working with cancer patients. So, like a quick background on me. I did my last clinical rotation of PT school at Stanford with their bone marrow transplant team, and then worked in an outpatient ortho clinic for like 6 months. And they called me and asked me if I want. They had an opening on the team. Reached out to me, hey, do you want to come back? Like, absolutely. I loved my experience there. Going through PT school, never thought I was going to end up working with cancer patients, but fell in love with it when I was there on rotation. And so I have been working with cancer patients the last almost 8 years now. And so I feel like even before I had heard the term trauma informed care, like it's what we do. Like you don't last this long working with cancer patients you don't if you're not compassionate, if you don't listen to what they're telling you, if you can't synthesize that information and understand how such a life-changing diagnosis affects every aspect of their life, not just their mobility and their function. And so, when I think about trauma-informed care, kind of as a like topic, it is how do we take all of a patient's past experiences, whether they are directly related to what we're doing with them or not, and like kind of mesh that all together. Because right, if you're not implementing, give me a second to form this thought. um, if you're not coming up with a cohesive strategy that is making the patient feel safe, making them feel heard, they're not going to value what you have to say. And so if we're not taking those past experiences that they've had, like I said, whether it is directly related to their, the treatment that you're providing or not, if we're not taking those into account and our patients are feeling like, they've had the same talk with multiple providers and it doesn't seem to be going anywhere, they're going to start losing trust. They're going to start becoming a little bit more defensive when they're having those conversations because they don't feel like their experience is being valued. And so I had a patient a couple months ago that came in, was having multiple falls at home, just wasn't getting up and doing a whole lot. Came in through the ED. They get to the floor. All the notes that are in the EMR from the docs and everything are, we're going to run all of these tests. It's most likely progression of her disease. This is where we're at. And so I'm talking to her. Her husband's there at the bedside, and it's like, okay, like when did all of this start? Because you just came in a couple of days ago. I'm just getting to you now. When did this all start? And she goes, well, a couple of months ago, I got a call from my oncologist that, things weren't getting any better. Things don't look worse, but we're not really seeing the response that we want to see. And so they had to switch one of her medications. Not something she was super excited about. They get this big, long list of side effects whenever they switch medications, right? So a lot of things on there that she was not looking forward to. So she wasn't eating well. She wasn't sleeping. She told me, because I gave her that space to have this conversation about, what is going on? What's happening? She told me, I was a little depressed when I got that call. It's like, cool. We're going to loop in dietary services. We're going to loop in your social worker. We're going to loop in psych onc. A week later, she's sleeping better. She's eating. She's ready to go home. Her weakness and her falls were not because there was something wrong with her musculoskeletally. It was all of these other things in her life are out of her control. And she's not engaged, so she's not getting up and doing anything. And it's a relatively simple fix, but if you're not asking the questions to get there, you're not going to get to that bottom. Yeah.
You're not going to get to those answers. Yeah. So to review, words matter. Create a safe space or create a trusting environment. I like trusting environment. It sounds a little bit less, just overused. Silence says a lot. See what I did there? I held. Yeah, there you go. Make sure it's asking, not interrogating. Make sure the goals are around the patient and they're not just part of that list. And finally, are you getting the whole story? Are you getting as much of the picture? Because you're never going to get all of it. Are you getting as much of the picture as you can with the tools that you're given? And who, what, where, when, why, and how are tools, and you can use them pretty damn well. Did I miss anything?
That's a great wrap up. I love it.
That was a pretty good wrap up. All right, last thing we do on the show. Are you ready for the parting shot?
Let's do it.
This is the parting shot.
All right, parting shot brought to you by our friends at the Academy of Orthopedic PT. Find them online at orthopt.org. They're a profession-leading current concepts of orthopedic physical therapy, taking you from wherever you are to maybe you want to take that OCS exam, but you don't want to take it unless you're like kind of confident, feeling competent, and that's what it does. It helps you instill confidence and competence. You got to take the test, but this helps you get there. All right, so that's our parting shot sponsor. What do you want to leave with the audience, Adam? What's your mic drop moment, your soapbox statement? What do you got?
So any oncology PT that you talk to is going to tell you need to have some basic understanding of how cancer affects patients, because it's not a matter of if you're going to treat somebody that has had a cancer diagnosis, it's when. Mm-hmm. We're heading towards, the NIH has this projection of having 24 million cancer survivors in the US within the next 5 to 10 years. No. So even patients that you're going to see for hip and knee issues, for back issues, they will most likely have had some kind of other cancer history in their past. So be educated on how different treatments affect patients. And there are lots of ways to do that. I have learned so much about oncology PT just through networking on Twitter. It's insane.
Yeah. And don't undertreat them, because that's just as bad. Right. Like, so don't just, and I was guilty of this myself, like seeing that C word and be like, well, then I'll just go easy. And it's like, that's a disservice. That's a disservice to that person.
Or even right, like in PT school, we know in the half-hour lecture that we get on cancer in the entirety of our program, it's, these are red
Red
flags,
flag,
and
man.
you're going to refer back.
Right.
And it's like, no, there is so much that we can do for these patients if you even just have a basic understanding of,
Right.
the treatments that they've been through and how they affect them.
Yeah, I feel like that's at least on the trend is positive in direction, right? At least since I graduated in 2016, because that's what it felt like, and I feel like that's not what I hear now.
Yeah.
Yeah.
No,
Awesome.
I think we're heading in the right direction.
Good. Perfect. All right. They say the best conversations happen at happy hour. Adam, thanks for coming to ours.
Jimmy, it was great talking with you. Thanks for having me on. Hopefully we get to do it again soon.